he has a dual personality, a duality in one. That is the Parkinson's disease and diffuse Lewy body disease. In other words, Lewy body disease causing dementia. So why he is a dual personality, we will come to know. Again, very important in neurological disorder, a very great neurological disorder, a degenerative type. We will welcome him, and one by one we will see the different personalities part of him. So welcome first Mr. Parkinson's disease. Mr. Parkinson disease, welcome. Welcome. Thank you, sir. Welcome. You can sit here. Yes. Thank you for accepting the invitation.
Thank you, sir, for having me.
Thank you very much, and there is no question about it. Again, you are a spotter. You can be diagnosed on spot with your clinical features. So obviously, you have depicted it: shuffling gait, no arm swing, your masked face, and this unilateral pill rolling tremors. So there is no confusion about Parkinson's disease. So I will be first talking about this personality. I know you are hiding two personalities.
Yes, sir.
And you have already informed me how I should go through this interview.
Yes, sir.
Yes. So first let us talk about one of your spectrum, that is the Parkinson's disease. And obviously this is the dementia podcast, so we will be talking about dementia. So again, I want to revise a little bit just for the epidemiology of Parkinson's disease. What is the epidemiology, sir?
So basically, most of the patients with Parkinson's disease eventually land up in Parkinson's disease dementia over the years.
Over the years?
Yes, sir.
Okay. First Parkinson's disease, its predominant clinical feature, then over the years, dementia last.
Yes, sir. Okay. Dementia develops last.
What is the Parkinson's disease prevalence?
So the prevalence of Parkinson's disease it increases as age increases in
so
patients.
The dementia part you are talking about?
Yes, sir.
Prevalence will increase.
Prevalence will increase with age, and it affects men more women.
More than the females?
Yes, sir.
Okay. So what is the basic pathophysiology of Parkinson's disease, just for the revision of our audience?
Yes, sir.
Pathophysiology of Parkinson's disease.
So basically there is a degeneration of dopaminergic neurons in substantia nigra pars compacta. There is a depletion of striatal dopamine.
Yes.
Along with this, there is a deposition of Lewy bodies at
Lewy bodies, a big thing.
Sir.
This is a big thing.
So deposition of Lewy
bodies. Okay.
At specific brainstem nuclei, substantia nigra.
Okay, and all this region there are deposition of Lewy bodies. So there is a dopaminergic deprivation of the substantia nigra and corpus striatum and the nigrostriatal path. So predominantly, if I am not wrong, two keywords coming from Parkinson's from you.
Yes,
that is, one is dopamine, one keyword.
Yes, sir.
Second is the Lewy body. That is the pathological hallmark maybe.
Yes,
talking about.
Yes.
And this Lewy body, the third keyword what I am listening from you is alpha-synuclein.
Yes, sir.
Okay, alpha-synuclein. These are the three pillars of the pathophysiology. Okay.
So basically, Lewy body is intraneuronal cytoplasmic inclusion bodies.
Yes.
Which stains with periodic acetylcysteine and ubiquitin. It is basically formed due to misfolding of alpha-synuclein along with ubiquitin and other neurofilamentous proteins.
Fantastic. So basically, it is a twisted alpha-synuclein.
Yes, sir.
Which forms a different configuration, that is the Lewy body.
Yes.
Looks like inclusions.
Yes.
Causing neuronal degeneration.
Yes.
Okay, fantastic, sir. So if I talk about the dementia part, we all know that you are a great disease, affect lot of populations, Parkinson's disease. We know all other the clinical feature along your hallmark. Everybody are so famous. Everybody know about the bradykinesia, rigidity and the tremors part. And they are the basic three, how the tremors are, I would say cogwheel rigidity, lead pipe rigidity, and so much of bradykinesia, shuffling gait, festinant gait, retropulsion, counterpulsion, propulsion, everything we know about postural
Yes.
hypotension plus minus when
Yes.
autonomic nervous system.
Yes.
But I will be more concentrating on because it is a podcast of dementia. How is the dementia like in Parkinson's disease?
Dementia and Parkinson's disease is most likely affect recall memory, but it spares episodic memory.
It spares the episodic
Episodic
memory,
memory.
if I am not wrong. Episodic memory means the memory which are especially retrieved, that is the time and place related memory.
Yes, sir.
Our experiences with time and place, okay, that is
That is
spared.
spared in this.
Okay,
This is-
the recall memory.
Recall memory is predominantly affected.
Okay.
Along with this, patient can present with visual hallucination, well-formed visual hallucinations, but
Okay.
patient is usually aware of this hallucination, that this is hallucination, not real.
Okay, they know that these hallucinations
Yes,
are
sir.
not real.
Yes.
And if I am not mistaken, you will also talk about the visual hallucination which comes in more vigorous form in Lewy body.
Yes,
Your
sir.
Lewy body counterpart.
Yes, sir.
Okay. So visual hallucinations do occur sometimes in Parkinson's
Yes,
disease
sir.
also. Okay.
Then-
So any other thing about the dementia part?
Yes, sir. There is also rapid eye movement, sleep behavioral disorder also there.
In Parkinson's, in this variant also, in your variant also?
It's
or
rare in
more
Parkinson,
Ah.
but it's more in Lewy body.
Maybe in the Lewy body. it will
It's
be.
more in Lewy body.
So here we will talk about the important thing was episodic spared.
Yes, sir.
Recall memory is and gradually the dementia part increases.
Yes, sir.
And the most important thing is it comes after long gap after the clinical presentation in
Yes.
the late stages.
As basically speaking, at least after 1 year of onset of motor symptoms.
At least 1 year of onset of motor symptoms. At least 1 year after motor symptoms.
Yes, sir. If it's before, it's not Parkinson disease.
Then we have to
look for other.
crunch our brain for some plus syndromes.
Yes, sir.
Okay. So what are the investigations in Parkinson's disease?
So basically, in clinical,
99% we have diagnosed it clinically.
Clinical.
You are so famous.
Yes, sir.
You are such a celebrity.
Yes.
You are such a celebrity that we already have diagnosed you clinically. But for research purposes,
Yes, sir.
maybe some neuroimaging work, what we can do for.
Basically, there is for clinical, there is MDS clinical diagnostic criteria for
Still there is a
Parkinson's
criteria,
disease, dementia.
Dementia. Oh, yes. Sorry.
For Parkinson's
So you are
disease,
now
dementia.
talking about a scale
Yes, sir.
which is for dementia part of Parkinson's.
Yes, sir.
Okay, can you highlight
So,
that?
in this there are two types of there. There are core features and associated features. So there are two core features. First, person should be a diagnosed case of Parkinson's disease.
Yes.
Second, patient has slowly progressive dementia, which is not affecting that much daily activities
Okay.
initially. Then started affecting daily activities of the patient.
Certain daily activities.
Yes, sir. These
Like
are
we
core
can-
symptoms.
Okay.
Second is associative symptoms. That is cognition and attention deficit.
Oh, later on attention deficit and cognition will put in.
Yes, sir. Then loss of executive functions, visual hallucinations, and memory part.
As the disease progresses, this is how the memory is getting hampered
Yes,
day
sir.
by day.
And second is behavioral or neuropsychiatrical features.
Neuropsychiatric features.
So patient is probably diagnosed as Parkinson's disease dementia if both core clinical features present and at least 2 of 4 associated features are there along with behavioral symptoms.
Okay.
Then you have to diagnose probably it is Parkinson's disease dementia.
Yeah. Quite a jingoism, but yes.
Yes, sir.
Still, it looks very easy to diagnose.
Yes, sir.
Even if we apply or not, still
Yes.
it is easy to diagnose. So, other investigations we do know that some PET
scan and SPECT scan we can do.
These are for research
In which-
purposes,
yes,
very
sir.
costly. Just for research purposes, there will be in those areas where
There is
dopamine
a
deprivation.
decreased uptake of dopamine biomarkers,
Biomarkers.
especially in posterior putamen and comparatively sparing a caudate nucleus.
Okay. We all know the drugs for Parkinson's disease.
Yes.
First,
Yes.
the levodopa, carbidopa combination with levodopa, and catechol-methyl transferase inhibitors, and MAO-B inhibitors. Okay, anticholinergics
Anticholinergics.
for the tremor part,
Yes.
and newer dopa
Newer
agonist.
dopa
Okay, we all know
Yes.
that. But I am interested in the dementia part.
Yes.
What drugs we can give?
There is there is no definitive treatment for Parkinson dementia part of Parkinson disease.
Okay.
There can be only symptomatic management.
Yeah.
So in symptomatic management, you can give cholinesterase inhibitors like rivastigmine, that is 6 mg twice a day, or donepezil.
Donepezil and rivastigmine we also encountered when we talked about the Alzheimer's.
Yes, sir.
That
Yes, sir.
person also told about
Yes,
this.
sir.
The same group of drugs.
Yes, sir.
Donepezil and rivastigmine. Any other?
Then there are atypical antipsychotics like pimavanserin,
Pimavanserin.
which is basically inverse agonist of 5-HT2A receptor, and it is used in Parkinson's disease dementia because it does not block dopamine receptor.
Oh, this is the advantage.
Yes, sir.
Okay, this is the advantage of these drugs.
So
Okay.
that's why it is specially preferable in Parkinson's disease dementia.
Can you please again highlight the drug's name, sir?
Pimavanserin.
Pimavanserin.
Yes, sir.
Pimavanserin.
It is a selective inverse agonist of serotonin 5-HT2A receptor.
Okay. And it is sparing the dopamine part.
It spares dopamine part.
Fantastic, fantastic.
Then there are other drugs like low dose clozapine can give some symptomatic relief. And for rapid eye movement sleep behavioral disturbance, you can give melatonin up to 20 mg per day.
Okay, okay.
If melatonin doesn't work, then you can give clonazepam, gabapentin, those drugs.
Okay.
Yes.
So it was a fantastic interview about one of your personalities we now.
Yes.
Now let's go to the second part of your personality, that is the Lewy body dementia. So what is the epidemiology? How it differs from the Parkinson? What is the epidemiology of Lewy body dementia?
So basically, incidence of dementia with Lewy bodies is 7 plus 100,000 person years.
So it's a little bit less.
It's very less. But as like Parkinson's disease dementia, its prevalence also increases with age and it also occur more common in men than women.
Okay, same thing.
Yes, sir.
Okay. When I talk of the presentation of dementia
Yes,
or dementia as a part of these disorders, is there any difference? Say Parkinson's disease, you told that dementia will come later on and the end stages.
Yes, sir.
Here it also comes in the later and end stages?
No, sir.
No.
No, sir.
Okay.
Here, neuropsychiatric behavior changes, dementia part can precede the motor symptoms or coexist with motor symptoms of Parkinson's disease.
This is a point to be highlighted.
Yes, sir.
This is a point to be highlighted to our audience, that dementia comes with the symptoms Lewy body disease.
Yes, sir.
Dementia with Lewy body disease. Or it can precede. It can be the first presentation, later on the motor symptoms of Parkinson's disease.
Yes, sir.
This is a very characteristic difference between the two.
Yes, sir.
Okay, Parkinson's disease, late dementia. Dementia first, Parkinson's symptoms.
Yes,
this
sir.
is a fantastic.
And second thing I can differentiate between two is in dementia with Lewy bodies, it is more likely that Alzheimer's disease can be co-pathology for that condition.
There are shock things you are giving. You are giving shocks, neurologic shocks. So we have to think that we have to rule out Alzheimer's.
Yes, sir.
We have to think about Alzheimer's also.
Yes, sir.
Even if we are getting Parkinson's feature, it can be a coexisting feature.
Yes, sir.
Okay.
Yes, sir.
So what is the pathophysiology of when you talk about the Lewy body dementia?
Yes, sir. Then Lewy body, the core, the first thing is primary action is due to Lewy body deposition.
Okay.
In the parts I mentioned, like specific nuclear, brainstem nuclear, substantia nigra.
So areas wise there is no change.
Yes, sir. And lastly, neocortex.
Lastly, neocortex.
Yes, sir.
Any change between the like you told, dopamine was the boss.
Yes, sir.
Here, dopamine is also the boss here.
No, sir.
Okay.
Here there is diffuse cholinergic receptor depletion. There is a diffuse cholinergic neuron damage.
Okay. Second shock.
Yes, sir.
Cholinergic neurons.
Yes, sir.
Parkinson's disease was dopaminergic neuron depletion. So here acetylcholinergic neuron
depletion is there.
in this area. Then it is a Lewy body.
Yes, sir.
Okay. But Lewy body is becoming the same
Yes,
thing.
sir. Lewy body is
but
same.
the neurotransmitters are changing.
Yes, sir.
Okay. Interesting. Very interesting. So now can you tell us about what investigations can be done?
So basically for Lewy body dementia, there is a Lewy body composite risk score.
A specific list?
Yes, sir. There is a 10 I think questionnaire.
Okay.
If there 3 or more than 3 questions are positive, then you have to diagnose possibility of dementia due to Lewy body.
So there is a separate scale per se, questionnaire per se.
But this is not very specific for dementia with Lewy body. It can also come positive in Parkinson's dementia also.
Okay. So
Then
what other things can be done?
Other things we can do is first rule out other common treatable causes of dementia.
Fantastic. Again, this is the first time an elite dementia is commenting from his mouth, treatable, quote unquote, treatable conditions of dementia to be ruled out first. Fantastic, sir. Fantastic.
Yes, sir.
Yes.
So for that we can do MRI brain
Okay.
to rule out any structural condition, vascular causes.
Okay.
Then
On common nutritional
On
causes,
common
and all
nutritional
those
causes,
things which are
vitamin
treatable,
B12,
thyroid profile,
thyroid,
vitamin
yes, sir.
B12, thiamine levels, CAO, vitamin D level, niacin,
Yes, sir.
and everything. So, what are the pinpointing features in the investigation,
so
which are usually not done in Parkinson's disease, but there are some investigation that is done for this disease specifically?
yes, sir. In CSF,
So
you
CSF we have to do.
CSF study you have to do, sir.
CSF we have to do because CSF we usually don't do in Parkinson's.
Yes, sir. So in
Yes.
CSF can show alpha-synuclein oligomers
Okay.
by same technique, the RT-quick technique.
Oh, that RT-quick technique.
Yes, sir.
This is a very dangerous technique. Dangerous things in the sense when I am pronouncing this RT-quick, and this is a new information for our, I think for the audience also. RT-quick. RT-quick. If I am not wrong, real-time Parking inversion recovery.
Yes, sir.
This was one of the hallmark clinical tests in CSF when we are talking about Alzheimer's disease also. Sorry,
Creutzfeldt
we are talking about the
disease.
Creutzfeldt-Jakob disease.
Creutzfeldt disease.
Yes, Creutzfeldt-Jakob
Creutzfeldt-Jakob
disease.
disease.
It was speaking of the PRPSC part.
Yes, sir.
PRPSC part. Okay, well, here it is also.
Yes,
it will
sir.
pick up the alpha-synuclein.
Yes, sir.
Okay.
And also CSF or blood levels of phospho-tau 217
phospho-tau 217
levels are raised in dementia dementia due to Lewy bodies.
Sir, can I please request you, if you don't mind, sir?
Yes, sir.
If you do not feel insulted, sir, can you just write the
Yes, sir.
investigation name, sir, for our audience? So CSF has been done.
Yes, sir.
Anything else, sir, in investigation?
So there are rapid eye movement sleep disorder. For this we can do polysomnogram.
So rapid eye movement, REM sleep disorder, you have already mentioned
Yes,
in
sir.
Parkinson's disease.
Yes, sir.
But here it is equal incidence or more?
It is more in incidence here, sir.
Okay.
Also
REM.
visual
hallucinations part, you have told that.
yes, sir. Even visual hallucinations are more severe in dementia with Lewy bodies.
Okay, REM, sleep disorder, visual hallucinations, more in diffuse Lewy body disease.
Desktop.
And not to forget, dementia starts,
Yes, sir.
dementia strikes, then clinical Parkinson's.
Yes, sir.
Okay, that's why maybe it is a Parkinson plus.
Yes, sir. And along with this, there will be cognitive dysfunction, attention deficit. This can also be present in patients.
Attention deficit and cognitive dysfunction.
Yes, sir.
Again, the same recall part goes.
Yes, sir. In this also recall part first and
Episodic
episodic
memory
is
is
preserved. Yes, sir.
Preserved.
Yes, episodic memory is preserved.
I just forgot. Sorry for
Yes, sir.
this gene you have told about.
Yes, sir. So there are multiple genes associated with Parkinson disease.
Yeah,
Like
Parkin1,
Parkin, Pink one, SMCA,
Yeah.
MBA. But
Why you want to written those names?
because this gene GBA, the glucocerebrosidase,
Glucocerebrosidase.
this is predominantly
Causing the
causing
dementia.
dementia part of Parkinson disease and also in dementia in Lewy bodies.
Okay. This is the specific
This is
gene
specific
for
gene.
specific gene for dementia.
Yes, sir.
Highlighted, boss.
Yes, sir.
Yes. So we investigation part. You want to say anything else? We go ahead. These are the main.
These are the main, and
Okay.
polysomnogram is
Polysomnography you added.
Polysomnogram
No doubt
added.
about it.
Yes, sir.
So what is the treatment part?
Same here also. There is no specific treatment for dementia with Lewy bodies.
Again.
Yes, sir.
No.
Only symptomatic management, which I mentioned
Same
earlier.
drugs you are
Same drugs.
taking.
Rivastigmine, donepezil, pivancil.
Prevention. We talked about.
Yes, sir.
So those are also in
Then other things you can do is supportive management.
Supportive treatment.
Like
supportive management.
usually in REM sleep disturbances, there is acting out dream. So patient can injure himself and his partner.
Okay.
So for that,
The patient will act his dreams.
yes sir. So that because there is a loss of skeletal muscle paralysis.
Okay, that's okay. Yes. When the skeletal muscle paralysis doesn't occur,
Yes sir.
then he is acting his dreams.
Yes sir. That may lead to injury to himself and also his
To
bed
prevent
partner.
that.
So prevent that, you have to keep
And we can
separate.
give benzodiazepines,
Benzodiazepines, melatonin.
Same
Yes, sir.
he sleeps at least.
Sleep circumstances.
I know.
Yes sir.
Okay. So okay, fantastic sir. Very difficult disease you are, and the way you explained yourself, too complicated, and you gave enough information to our audience. So thank you sir. Parkinson's disease at one end, Lewy body dementia at the other end, doing toto, alpha-synuclein spectrum and dementia. Thank you sir. Thank you very much.
Thank you sir. Thank you for having me.
Our next guest is a surprise entry. It's late. I don't know whether the next guest will come late, or I don't know what is late. But she has come already, so she is not late. She is something else late.
No, I'm never late. My name is late. I'm never late.
Welcome, ma'am. Sorry, I felt that it's late. You will come late. Oh, you are not late.
No, I'm never late.
Obviously,
My
you are on
name is
time,
late.
but your
Yes.
name is late.
Yes, my name is late.
Name is late. Late dementia
Yes, late dementia.
or late causing dementia.
It's late dementia.
Late dementia.
Dementia.
Okay. So what is this late? Can you please introduce yourself?
This is my name. Limbic predominant age related TDP-43 encephalopathy.
Limbic age related TDP-43 encephalopathy.
Yes.
Quite a jingoistic name.
Yes.
Are you a new entrant in the world of dementia, or you are already existing? That means you are recently. This is a recent thing.
No, it's not a recent. It's something new. See, I am basically a neurodegenerative disease in the form of dementia. I mostly affect older people, and age more than 80 is the main risk factor for me. And I do memory loss and cognitive decline of the patients.
Okay.
And you know what? The most important thing is I'm a sister of Alzheimer disease too.
Okay.
Yes.
So you are a cousin of Alzheimer's
Alzheimer disease.
This is actually new for me, madam.
Hmm.
This is new for me. You are Alzheimer's spectrum, a cousin of Alzheimer's.
Alzheimer disease, yes.
Okay. He didn't mention about you. Okay.
Hmm.
Obviously, I didn't ask about the family tree of Alzheimer's.
Yes.
Okay. So, very interesting. So basically, what is the pathophysiology? What do you do? Any genetic
See,
predisposition?
as the name suggests, TDP-43, I built in TDP-43 protein in the limbic regions, like amygdala, hippocampus, and I can also spread into middle parietal gyrus
Okay.
that way. And this thing can cause the memory loss and the cognitive dysfunction of it.
Cognitive dysfunction of memory loss.
Yes, that is the main pathophysiology.
Main pathophysiology.
Yes.
And if we elaborate the memory part, it is only the which part of the memory. As I will just take something 1 minute of your not late.
It's
When we
like-
classify the memory disorders,
Ji.
one is an implicit memory, one is an explicit memory. The implicit memory is already we know things. We do not consciously try to retrieve information from our brain,
Yes.
like riding a bicycle.
Hmm.
I have not ridden a bicycle since 30-40 years. But if you keep a bicycle, I will ride it.
Yes.
I can swim. These are implicit memories.
Hmm.
I am not creating a conscious effort to take out what is the information.
Hmm.
And second is the explicit memory.
Yes.
And that has been divided into, say for example, one form is called the episodic memory. Any memory related to the time and place related. मैं पिछले बार वहाँ गया था तो यही टाइम में मैंने क्या किया था. That type of thing.
Yes.
And second part is the semantic part of the memory, where usually the memory loss occurs, especially in word findings,
Yes.
word recognition, face recognition, object naming or object information. That memory is lost. So in this spectrum, which part you?
My part is semantic part.
Oh, the semantic part.
Yes, I have a difficulty with word finding things, face recognition things,
Okay.
and then in the later stages it can go on the executive dysfunctions also. So that is the main part. That is called a semantic memory.
Semantic part you
loss.
affect the most.
Yes, sir.
First trick is you are affecting people at the fag end of life.
Yes.
So first thing is whether it is a normal benign memory loss of an elderly.
Yes.
Second, that Alzheimer's is again coming here.
So in this way, I can overlap with my brother Alzheimer's pathology also, and this makes my diagnosis very tricky and very challenging. So oftenly I am underdiagnosed or misdiagnosed.
Yeah, obviously.
Yeah.
Obviously.
So people also call me hidden culprit because of it.
Obviously, it is so obvious.
Yes.
So obvious.
Yes.
Yes. So how do you diagnose?
Okay, basically my definitive diagnosis is only on autopsy, which is pathological diagnostic.
Okay.
But right now, because of many researches going on, I can be diagnosed on the basis of biomarkers of CSF and blood on TDP-43, and also through scans like MRI. On MRI, I show hippocampus atrophy, and my parietal lobe, the loss of parietal lobe can also be seen on MRI.
Okay. So is there any treatment?
I have no treatment. I am
Yeah.
untreatable.
Yes.
There's no disease modifying treatment for me.
Nothing new.
Yes.
You don't have any treatment.
Yes.
Sadly. Any last message you want to give to our audience?
The message which I would give is, do not get confused with Alzheimer's, because that is the one thing I can overlap with, and I can be underdiagnosed or misdiagnosed. So
We have to keep you in mind.
Yes.
Alzheimer's will be definitely, you will be topping the list. But in also, as you are hidden, in our hidden differential diagnosis, Alzheimer's like presentation, fag end of life, you definitely come as a differential
Yes.
diagnosis. Thank you, ma'am. Thank you for enlightening us. Our next guest, again an important member in the dementia family, well known for his movement disorder part, a neurodegenerative disease predominantly presenting as a movement disorder, later on affecting the dementia, affecting the brain, causing dementia. I will welcome here Huntington's disease, well known as Huntington's chorea. Let us see the dementia part and how it causes dementia. Welcome, Mr. Huntington's disease. Yes, chorea, coriform movements. Yes, fantastic. Yes, it's so obvious. We can identify you as a part of a degenerative disorder, Huntington's disease, predominantly presenting as chorea. Okay. Again, I will request you now to introduce yourself.
You might have heard my name as Huntington chorea because of my striking coriform involuntary movement. I am less known for my profound effect on memory, cognition, and psychiatric disturbances.
You are less known.
Yes.
People are more knowing as per the coriform disorder.
Only coriform activity.
Okay.
I am a progressive fatal autosomal dominant neurodegenerative disorder.
Progressively fatal.
Progressive fatal. And I am characterized by motor symptoms, cognitive dysfunction, and psychiatric disturbances.
Okay. Thanks for this introduction. What is the basic epidemiology? How you affect the globe? How you affect?
I generally affect every 2 to 8 person in 1 lakh population, especially males of around age 25 to 45 years.
Okay. Still a younger lot.
Yeah.
You affect the younger lot.
Yeah.
So what is the basic pathology? What happens in the brain when you
Actually, whenever there is a repeat trinucleotide sequence of CAG of more than 40 on chromosome number 4, that causes ubiquitin and Huntington protein formation, and that accumulates in the nucleus of the neuron, causing neuronal death, and that neuronal death causes caudate nucleus atrophy and putamen atrophy.
So basically, if I say it is a trinucleotide sequence disorder,
Yeah.
multiple trinucleotides are getting affected.
Yes.
And if the number chain increases, that's the problem. The extra chains will accumulate ubiquitin and all this pathology what you were told, degeneration of caudate nucleus and putamen.
My severity increases.
And it is a CAG repeat disease.
Yes.
Also.
But yes, if the number is less,
Hmm.
say around 36 to 39, I become less severe.
Oh, even if it is the mark, the cutoff point is gone, but still the number is less severe.
Yes.
More the number unfoldings,
Yes.
more severe. And it is CAG means the cytosine, adenine and guanine.
Yes.
Trinucleotide repeat. Fantastic.
But let me tell you one thing.
Yes.
I caused the anticipation.
Anticipation. Take minute. Let me write it. This is the first time I am hearing something. Anticipation.
Yes.
Who will anticipate you? I don't know what is anticipation.
In the subsequent generation, I become more severe and my number increases. As
Dissipation.
the generation goes on,
Uh-huh.
I become more and more severe, and the number of CAG repeat increases.
So that automatically increases.
Yeah.
That means you anticipate that in the further generation family tree,
Yeah.
if somebody is going to have Huntington's disease, that is you will come in the subsequent family like a curse
Yes.
in more severe forms.
Yes. Also, in the early phase of the life.
Also in the early phase of life. That is really dangerous. That is really dangerous, and you are a real monster. Please don't mind. Okay, fantastic. Okay, what happens then?
Then
Clinically, what happens?
Clinically, I present as I cause motor symptoms,
Yeah.
and if you ask, then it is a rapid, non-pattern, and semi-purposeful, involuntary movements.
Yes, we saw that. So fantastically you did it as you do in your praise. Eh? Okay, yes.
Also, I affect the gait. I causes the gait disturbances,
Yes,
dystonia. In cognitive dysfunction, if you ask,
Yeah, that is the important thing because
Yeah.
we are dealing with the memory part in this podcast.
I directly decrease the span, the attention span of the patient.
So one is attention span is decreased.
Yes. Also, I cause the subcortical dementia.
Subcortical dementia.
Yes. In that, the patient they are unable to recall things, and in the later part, I also involve the episodic memory.
Okay. To again highlight episodic memory.
Yes.
That is memory related to time and place related memory is lost
Yes.
and recall is lost.
Yes.
Okay.
In psychotic disturbances, if you ask, then I cause irritability, apathy, and in severe form, I can cause psychosis as well.
Okay. How do we diagnose you?
If you want, you can diagnose me clinically. But yes, if you want to see me, you can see me on MRI or CT scan.
Okay.
I present as caudate nucleus, caudate atrophy or putamen atrophy and statal degeneration. Also, you can see as ventricle enlargement.
Ventriculomegaly.
Yes.
Okay. Is there any treatment?
Unfortunately, you can't treat me. But yes, if you want, you can decrease your dopamine levels by giving tetrabenazine. And also, if you have any psychiatric symptoms, then you can give antipsychotics like olanzapine and risperidone.
But ultimately it is a fatal disorder and it is untreatable.
But I must say, the research are going on. You are behind tackling me, and there are RNA interferences and gene editing sequence like going on.
Targeted
But yes,
therapy.
they are under research. Yes,
Okay.
like CRISPR and Cas9 therapy.
Okay. Thank you very much for highlighting us about how you come, what you do, and we should not underrate you just as a movement disorder. Thank you very much. Thank you.